We're here for the NHC Weight Management and Health webinar. And let me give you a little bit of welcome. My name is Susan Gaffney, and I am the Executive Vice President here at the National Health Council. And we're really pleased, as I've said, to have you join us today. I expect the next hour will be chock full of new information and insight and just stimulating ways to think about an issue that obviously we all care about. Our presenters are very expert in the topics that we're covering, and they'll be sharing ideas and best practices and posing some questions that I think will be really useful for all of us to consider. As I've already said, we really encourage you to use the chat throughout the session. It's available there for you. And you don't have to wait for a break in the conversation. Go ahead and put it in there, and we will go back and make sure that your questions get addressed to the extent that time allows. So for those of you who are not members of the National Health Council and are joining us, just a little bit about who we are. Created by and for patient organizations over 100 years ago, we are really focused on forging consensus and driving patient-centered health policy. Access and affordability are kind of the North Star for us, as we know that that's what patients want and need in order to live their best lives and have their best health. We have over 160 health-related organizations in membership, really representing the depth and breadth of the health sector. Our primary members are patient organizations that work in specific disease areas, and they are our majority in terms of the stewardship of the organization, but we are thrilled to have so many other allies and partners join us in membership, in providers, researchers, family caregivers, all kinds of folks who care about these same issues that we do. Any questions you might have about membership, you are always welcome to check out our website or shoot us an email. So just a little bit on the details. We will be recording. That's already happened at the top of the session. And the link to listen to things again will be distributed to attendees. Everybody except us speakers will be on mute, and you can use the chat function for questions. There is closed captioning available. If that was something that you didn't see when you came on, you can find that. And if you have any questions or technical issues, you can use the email there at NHC meetings, and my colleagues would be more than happy to help you. We always have to say that when we have speakers, they represent their ideas and opinions and those of their organizations, not necessarily those of the National Health Council. But I feel like there's great kinship in these speakers, and so I'm happy to bring forward what they have to say on these issues. Just a few details of for our members who are here joining us on the call. We have a lot of events coming up here in the end of the year and into next year with our International Patient Forum. Our health equity work will be presented through a Lunch and Learn next week. Our representatives retreat in Annapolis next month, which is really focused on federal advocacy and policy. Our annual membership meeting in December, and then our leaders conference in February, and our patient engagement event in May. So we certainly hope to see many of you at those events in the coming months. Want to give a special shout out and thank you to Novo Nordisk, who is supporting our work in this area and have been great partners in that. And now on to the heart of the matter. We have Dorothea Vafiadis and Joe Naglowski. I practiced their names in advance, and I think I did okay, but I'll leave that to them to tell you whether I did or not. And they're coming. Joe is coming to us as the president and CEO of the Obesity Action Coalition, and Dorothea is the senior director of the Center for Healthy Aging at the National Council on Aging. They both have deep expertise in the issues that we'll be talking about today. And I promised them that I wouldn't go deep into their bios because it's so uncomfortable to sit and listen to somebody else read the details of your life back to you. So I am going to invite them to introduce themselves, their organizations, and their work a little bit more deeply. And once they do that, I invite them to offer some opening remarks on on the state of obesity here in the United States. How did we get here? And some thoughts on what are the implications of just leaving things as is, the status quo, the persistence of the status quo. So I will turn it over now to Dorothea and then Joe to tell us a little bit more about themselves and offer some thoughts on that first question. Thanks so much for being here.
Thank you, Susan. Good afternoon, everyone. I'm Dorothea Vaviatis, and the National Council on Aging is the national voice for every person's right to age well. And so NCOA believes that how we age shouldn't be determined by gender, color, sexuality, income, or zip code. We work with thousands of national and local partners to provide resources and tools and provide best practices to ensure that every person can age with health and financial security. So much of my work revolves around the health piece in terms of helping older adults become empowered with health and health programs at the community level, but also building out into the national level. NCOA was founded in 1950, so we're the national oldest organization focused on older adults. And in terms of, the question around health, what we ask ourselves every day is, are the people that we're serving, are they thriving? Are they living the best quality of life possible? Or are they suffering? Or are they merely surviving? And those three different areas of quality of life are critically important to us. And I think those are extremely important to the concept of better managing chronic conditions. We work every day to make sure that is a reality, that older adults have the right places, the right resources, and the tools to be empowered. And we know obesity is a major barrier to healthy aging for millions of Americans age 60 and over. So I think the challenges that impede older adults with obesity are ranging from accessing the full range of treatment options to going and getting care and being treated with dignity and respect. And so I think, we know that there's an impact on communities of color, even more than there is on, it's extremely important for us to update and advance progress in these areas because it's a matter of equity and access. So I'll stop there and let Joe have a turn at this, but so nice to be here. Thank you for the invitation, Susan.
Thank you. Joe.
Thanks, Susan. So I'm Dorothea. I'm Joe Naglowski. I manage the Obesity Action Coalition, which is the patient advocacy organization in the obesity space. We're now about 20 years old, just shy of 20 years. And we were actually formed after a legislator stood up at a meeting on obesity and said, I'm asked every single day to do something about the obesity epidemic. But it's always by someone in public health or by a doctor. I've actually never been asked by someone with obesity to help me around this issue. And so we were created to fill that voice. And we spend our time respecting that original view, right? We try to raise the voice of people living with obesity when it comes to this serious problem of obesity. And in addition, we also put forward what we think are very high quality education materials and support materials to actually support people in their journey. So if you woke up today and you said, today is the day I want to do something about my obesity, we're there to help people kind of cut through the noise and find the resources that they need to be able to move forward. And frankly, to your question, I think that's the real challenge right now. If we look at obesity, we've been fighting this battle now. The obesity epidemic's been getting worse since the 80s. We're 40 years in, and the reality is it doesn't seem like it's getting better. And there's so much noise, but there's very little progress. And we think one of the reasons there's not as much progress is because, lots of people talk about things about doing things to us, those of us with obesity, instead of with us, right? And so we're pushing very hard to move that forward. But to what Dorothea raised, I think the system, the limitations in the system, which means if I woke up this morning and said I want to do something about my obesity, that the system isn't set up to actually accommodate that, right? There aren't evidence-based resources, there isn't insurance coverage, there aren't providers that are well-trained. All of those barriers are keeping people from getting the care that they need. And I want to be very clear here that this is both an individual and a systems problem, right? We need to affect the system. And again, to give the individuals the tool to do it, because like someone like me who has a strong genetic history for obesity, every male in my family is dramatically affected. It is up to me to deal with the hands of cards I've been dealt in life, right? It's up to me to do that. But the system doesn't allow that in many cases, and we're trying to change that system to make it better for all people living with obesity.
Well, thank you both for the incredible work that you're leading, and your organizations for being, really sort of front and center on addressing these issues. Joe, could we hear from you to dig a little bit deeper into how the challenges of obesity affect different groups in our society differently?
Yeah, so I think one of our challenges in addressing obesity is it's not a homogeneous condition. All of us who are affected are not affected the same way. And the motivations to address obesity are different in people. And I want to be very clear with definitions here. To me, obesity is having too much body fat that harms your health. And it's not necessarily just living in a larger body. I'll be controversial here and I'll say there are plenty of people who live in larger bodies that don't have obesity, right? Because their body fat isn't affecting their health. And so we have to be careful as we look at groups where we apply kind of across the board statements around this issue. And so some people may have significant cardiometabolic problems, and there's really probably an obvious reason why you need to address your obesity. Others may have functional problems, and others may have socioeconomic problems that are associated with their obesity. And all of these are meaningful problems, but we have to think about each of them may take a slightly different approach to address the issue. But we also know that from the statistics, and very, very clear, that obesity is more likely in certain populations, right? It's not only for example, African-American women have much higher obesity rates than other populations do. And so we may have to pay special attention in some of those groups to make sure that we're developing tools that again, help them, not stigmatize them as they move forward with their condition.
And there's such a strong co-occurrence with obesity and other chronic conditions. So what does that mean for how different people are affected, and what kind of, and really the access problems, I feel like is what you've touched on here, is that, the system doesn't necessarily respond to obesity as a comorbidity and part of your health journey and how to manage your chronic conditions. Can you guys expand a little bit on that?
Yeah, absolutely. I think, as you know, obesity is linked to over 200 plus comorbid conditions. And, when you think of the older adult population, they're very heterogeneous and they're not all one, right? Everybody over 60 is not equal, but at least 75% are living with more than 2 chronic conditions. So if you can eliminate obesity, you have a high chance of really helping manage those conditions, and even in some cases eliminating them and improving health and quality of life. And that's what it's all about.
Absolutely.
And I agree with that. And I think one of the things we often miss is that in addressing obesity, we will address some of those other comorbid conditions, right? And so, if we see with even modest weight loss, starting at 3% weight loss, we start to see diabetes improve, right? And then as we get to even greater weight losses, in the 15 to 20%, you see some of these cardiovascular outcomes improve pretty dramatically. And so sometimes I get frustrated, right? Because oftentimes I see our payer system paying for all the complications of obesity, but then many of them put barriers in front of people to actually address the core issue, which is obesity. And if we could address obesity, we might be able to eliminate or dial back some of those conditions. Now, to be very clear, not every health problem is associated with obesity. And actually, one of the biggest complaints we hear from people with obesity is I go into my doctor's office or my healthcare provider's office and they blame my weight on everything, right? Mm-hmm. And so we have to remind our healthcare providers to make sure they look just a little bit deeper, right? To make sure they're not jumping to a conclusion there. But obesity does cause, again, or is linked to, I would think it's 240, 250 different health conditions. And it is remarkable that we have a tendency in this country to exclude services to address obesity. Oftentimes you'll see exclusions in insurance policies by employers or insurance companies that say, we don't cover obesity, even if it's causing health-related complications. And that's one of our big barriers and one of our challenges we have to address.
Oh, absolutely. That's so frustrating. Um, so Dorothea, I know a lot of the work that you all lead is really focused on community level interventions and the impact that can be had in those settings. Can you talk to us more about what you learn and what you see is effective and what gaps you might see out there in doing that kind of work?
Absolutely. Yeah, and if you wanted to share some of those slides, I can certainly talk through that. But we created 2 years ago, we held a roundtable with experts. Next slide. And we focused on obesity and equitable aging. And some of the partners at this roundtable included diverse elders from across the country with groups like the National Indian Health Council and the Alliance for Healthy Aging Research and the National Hispanic Council on Aging and the National Caucus and Center on Black Aging. So you could read the article to find out more about who was there, but we came up with 10 drivers of inequities and 10 challenges and solutions, if you will. And, we used this to set off a campaign over the last 2 years to really dig deeper into what's going on in community, what are the barriers and what are the challenges. And so these are some of the drivers that came to the fore. The proceedings is published in the American Geriatric Society Journal. But we've done some work in community to really hear and inform our campaign by those with lived experience. So you could go to the next slide, please. And the first phase of our work was designed in community with 4 different senior centers to look at, if we create a toolkit, can they host a roundtable to talk about barriers and challenges of obesity? And then we went to a second phase where we held more town halls that were a little bit more focused on getting medical experts and also having people with lived experience on a panel and communicating to each other to talk about challenges and barriers and break down some of those stigmas. And so this just gives you an idea of all the places we've had events where we've really captured input from at least 400 plus older adults in their communities. Most of these were happening in senior centers. We had it at a church, and there's a lot of interesting feedback that we've uncovered. Next slide. But to give you a sense of the kinds of conversations that were happening at these town halls and roundtables, these are just some questions that were thrown out there, like what limitations does living with XX weight have on your quality of life? Or what can providers and insurers do so more older adults are treated with respect, especially those living with obesity? What are the barriers in your community to access healthcare and quality treatment? And what type of information do you need to understand your healthcare options? And these are the kinds of questions that were to the older adults themselves. On the flip side, there were also questions for some of the medical participants that could be MDs, nurses, dietitians, exercise scientists. And so we got some very powerful information. Next slide. And here's what they said. We found some trends related to, they want to be spoken to with dignity and respect. They are themselves, older adults are themselves caregivers. And so they're kind of navigating, how do I care for older adults and my loved ones who are living with obesity? At the same time, if I have obesity, I may not be paying attention to caring for myself as much as I am my loved ones and my partners, because I'm playing the role of a caregiver. We had people ask, how do I know what my care plan is? Everyone knows. We had a lot of people talk about how they felt like it was their fault. They say, I know what to do. Everyone knows what to do. I just can't do it. I don't have the willpower. And people assume that they're living with obesity because they're having a hard time, because it just comes with age, because that's what they've been told. And one of the town halls, a woman stood up and said, "I feel invisible. I'm living with obesity and I feel invisible." And you could hear a pin drop in that room because it was a very powerful statement, very emotional. Next slide. And so we're capturing these themes, and the end result will be to create a patient bill of rights. But here are some more, observations. A lot of times people are talking about they don't have that relationship with their doctor or their health provider. They don't know how to access care. They don't get information that's easy to access and understand on nutrition, exercise. And oftentimes, we've heard from a community organization, a clinic, who said, they're starting to make their ER rooms and their clinics so that they do have the capacity to treat and handle with respect older adults who are larger, and all people who are larger, quite frankly, reinforcing some of the facilities and creating ramps and creating lifts so that older adults and those living with obesity can do things independently and move around in a room in a way that's dignified, right? Next slide. And so, a lot of those are talking about one of the town halls had information, a word cloud of what the people that they had a focus group before the meeting, what people feel like in this community before they go to see their healthcare provider, and what do they feel like after. And before, people felt like a nervous wreck, or they were very anxious, or they wanted to avoid the appointment. And afterward, they felt lucky, relieved. They were glad it was over. These are real people stories, and this is very powerful. But what we did see, and I know this is of interest to your audience, Susan, is that there's a lot of multiple stigmatized identities with these older adults. They're not only being stigmatized as older adults in the healthcare system and overlooked, but they're also being stigmatized for living with obesity and the chronic condition of obesity. And so they're really facing multiple challenges. I think it was powerful to see many of the medical providers who were with some of these town hall groups give advice and talk about, you should have a patient advocate. If your health provider isn't offering you one and you can't figure out how to get one, you need to go to a different provider. And people were very excited to embrace some help that way. But people are looking for tips, how to go into an appointment. What if I have a list and they can't get to it all? And thinking about ways that they can really interact in a way that they're treated with dignity and respect. And I would just say, next slide, what we did also see in some of this work in community was that it's important that they have access to education and care. Oftentimes, the information and education comes from sources that aren't always reliable, like TV ads or word of mouth. Yeah. And so this kind of work we're doing in communities, helping people identify trusted and credible sources, and really, thinking about how, what the big need is. How do we provide culturally sensitive education in a way that's resonating and meeting people where they are? And finally, the last slide is just some pictures, which I think are powerful. One of the communities invited their emergency care response team from the county so that they could hear from the older adults in breakout groups what's important to them. And I think especially in a crisis situation where emergency medically trained people would go and deal with older adults, there's a certain nuance, right? You need to know how to care for an older adult who's in a crisis situation. And so they were really listening and talking about obesity. And it was a real powerful way of exchanging in community. But I think, what we've heard for most of these situations, like this is the first time we've ever had a conversation about obesity in this way. And so as much as it was powerful and meaningful, and we're gathering this information, it's very shocking that people are just learning how to use the word obesity, and so we're really fortunate to be able to have this experience of gathering this information.
Such powerful stories, Dorothea. Thank you so much for sharing. And it really struck me, like you were saying that, for some people, this is just learning how to use the words and in the way that they talk with their healthcare providers. And I've certainly heard people talk about either, it kind of feels like either their healthcare provider can only see this issue and everything is filtered through that lens, or the healthcare provider is nervous to talk about it or avoids talking about it. And that also leaves the patient feeling, like this is something I'm struggling with and I need to be able to talk about it, but now I don't feel comfortable because you're not talking about it either. And so there's it's such a struggle to find the right balance and find the language, the tone, the respect that everybody deserves when they're in the vulnerable position of being with their provider. And that whole idea makes me think, Joe, what do you think about the balance between prevention and treatment? Like, what's the right combination to get us to a better place as a culture?
Right. So I think, oftentimes in this space, people should, you might see the headlines, lately have all been about these, new medicines that are GLP-1s. And now no one's going to care about prevention anymore because they're all going to take medicine. That's not true. Right. I think what we have to do is find the balance. Right. So I live here in Tampa, Florida, and I live in Florida, so I have to wear sunscreen every day. Right. But if I wear sunscreen every day and that's my preventative measure. But if I actually get diagnosed with some form of skin cancer, the treatment changes, right? I still wear sunscreen every day, but my provider then does something else. And I worry sometimes when we talk about obesity that people think that it's just be a one size fits all. Like, let's just change the food environment. Let's be very clear. I'm all for changing the food environment. I should do that. I'm not actually convinced that if we simply change the food environment, that no one would have obesity anymore, right? That ignores all the biology, set point theory, all these other things we understand about obesity. And so we have to find a balance of both. And so I would say, yes, we need to make the healthy choice the easy choice, but we also need to make it so that if someone is struggling, that they can get treatment. And by the way, when you make the healthy choice the easy choice, it makes their treatment longer, have a longer effect or have a better chance of success in the long run. And I also want to pick up on what Dorothea talked about and your last comment. This, talking to your healthcare provider about obesity is hard. And we spend a lot of time, and there are a lot of people working on trying to teach healthcare providers to have better skills to engage around this conversation. One of the harsh realities is most healthcare providers receive little to no training about obesity in their healthcare training. And so they are learning, what they have just from trial and error and and haven't actually been developed the skill set to do that. So we spend a lot of time working on that. And I have a lot of optimism that our healthcare providers are going to get better skills and learn how to have these conversations in a more compassionate and empathetic way. I can tell you right now, as a person my obesity is pretty well treated right now, but who hasn't always been in the case, that everyone with obesity, if you've ever struggled with your weight, you remember the first time your doctor talked to you about your weight, and it is likely not a positive experience. You remember it because it's a negative experience. In fact, every time I go to the doctor now, I relived that experience early on, and it's one of the things struggles for me personally to overcome. And so we have to teach our providers to have better conversations. With saying that, I just picked on providers. I want to say that it was a skilled healthcare provider who had a compassionate, empathetic conversation with me that led me towards my better health as well. So I think you can the balance of those. And so I would just challenge everyone to think about, especially our healthcare providers watching, to think about how you are engaging with people. Think about the language you use. Model language. You see us all here. We say a person with obesity. We don't use other words. We don't use the obese or fat or any of those other things. To talk about this from a scientific standpoint, but do so in a way of compassion and empathy. And remember that just about everyone who struggles has tried to address this at some point during their lifetime. It's not a lack of trying, right? It's a lack of having the right tools to be able to do so. And one of the things we often say is, Joe, you failed this treatment. And that's not true. The treatment failed me, right? And it's time for them to move on to what other options are out there.
Such excellent points from both of you. I feel like you both are really starting to touch on this, and I wonder if we can go a little deeper around stigma. There is so much stigma, and what do all of us here gathered on this call act in the health system in different ways from our roles? What do we need to understand about stigma, and what can we do to be part of a movement of destigmatizing obesity?
Dorothy, you want me to start? So this is my
Sure.
area of passion, right? This is where I spend most of my time. I will be honest with you. I mean, somehow in making obesity bad, we've made the people with obesity bad, and that is the main problem. I want to be very, very clear here. If you stigmatize someone because of their weight, you are not motivating them to lose weight. And in fact, we have very good data repeated over and over again that if someone is stigmatized because of their body size, they turn to food to cope with that. So you're actually making obesity worse when you stigmatize someone. And so we've done a number of things, from national public service campaigns, the Stop Weight Bias campaigns that really talks about how bias impacts people's lives, to working to introduce legislation in certain states and cities to say, you know what, it's not okay to discriminate against someone because of their body size. And that is a real issue, right? Many people are denied a job. In fact, unless people on this webinar right now, unless you live in the state of Michigan, your employer could fire you today because of your body size. And you are not protected in any way, shape, or form, right? It is perfectly legal to discriminate in an employment session against someone with obesity. And so this is a real challenge, and there's much work to be done. The other part of this that doesn't get quite as much attention is the impact that stigma has on an individual in terms of them internalizing that stigma. So, a lifetime of stigma, right, that most of us with obesity experience, we actually start to believe those things, right? And honestly, when I look in the mirror, the things I say to myself are way worse than anything anyone's ever said to me publicly, because I've internalized those attitudes. And we're now just doing the research to try to understand what tools are available to help people deal with that internalized stigma. Because again, that internalized stigma also is keeping us from seeking and or being effective at the care effectively utilizing the care or treatments we're being offered. So there's much work to be done in this space.
Yeah, that's absolutely right. And although, we're representing the older adults, I know that stigma starts in kids, from bullying all the way through the life to end of the life course. So, to have that repetitive message, like Joe said, in being something in your environment and having the opportunity to internalize it across your life is very powerful. And I've read some data that say people who visit healthcare providers, if they're using stigmatized language, they're 24% more likely to avoid future healthcare provider visits because they don't want to be exposed to that. Yeah. And when you look at, the other data, and I'm sure Joe has a lot more information, but I know that some of the stigma really reflect negatively on people doing the things that we want to see in terms of healthy lifestyle, like physical activity. They're less likely to be physically active because that stigma has an experience and an effect on them that they are not interested in doing it. And there's been some studies that say they're less likely to engage. They have less enjoyment with sports. I mean, it goes on and on if you look at kids over the trajectory of their life course. And so I think it starts early, and I think it's an important systemic issue that we need to address because it's not just a one-off. It's embedded in our society.
No, it really isn't. And just, my background is in working in patient advocacy around mental health, and just that is certainly a major area for comorbidity with obesity for a variety of reasons. But the way that one feeds the other, and that vicious cycle that so many people get into, that, their health suffers in other ways because of the stigma associated with a condition, and obesity is certainly one of those. So I think that anything that we can do as a community to address those things, those are the things that are well within our control, right? And that's us as a group, not individuals who are, managing the challenges of all kinds of health issues. We can all do better at being a voice that doesn't stigmatize folks in this community as well as others. So thank you for your guidance and providing resources on that. Given the sort of the depth and breadth of the problem that we have in this country, what are some of the higher level sort of strategic points of intervention in the sort of systems change in the policy landscape that have promise of really addressing some of these issues in a place that can have an effect for a lot of people.
I think one that we've talked about a couple of times already is this idea that we change the system to allow for, again, for people with obesity, people who really have harmed health because of their extra body size, because of the extra body fat, that they have access to treatment. Unfortunately, the vast majority of us don't have that. Again, OEC is a small charity based in Tampa, Florida. For no amount of money can I buy health insurance that includes obesity care for my employees. For no amount of money. It's not even made available.
It's
right?
because it's not even,
yeah, the system doesn't allow for that right now. If I was, pick another large Florida company that has thousands of employees and you're self-insured, of course you could add those benefits, but they don't allow it for us small employers, and I think, or even on the individual market. And so I think that's one of the barriers we have to overcome, understanding that in that doesn't mean that everyone is going to, and I think this is one of the things I hear most often, everyone's going to jump to the most expensive therapy. They're going to use bariatric surgery or one of these new anti-obesity medicines that's come out, but that's actually not what history tells us, right? Bariatric surgery utilization, less than 1% of people eligible use surgery. Even our diabetes prevention programs, counseling, things along that, the utilization is less than 1%. So not everyone is ready for treatment at any given time. So I think we have to push back and say, wait a second, let's stigma. Again, I often say to people, your stigma is showing, or your bias is showing, because you're treating obesity differently than you are other conditions, right? By saying, well, lots of people are going to run out and it's going to be too expensive. And I'm like, well, but we can design systems, and there are really bright people in those spaces who could design systems to say, let's make sure the people who most in need get access to it. And then we can overcome some of the kind of these equity barriers we have. Because one of our challenges in the obesity space, because so much of it is driven by your ability to pay to get treatment, is that it's completely inequitable, right? The reality is, for many cases, it's just rich white women who can afford care for their obesity. And that's just fundamentally not fair. We need to change that system to make sure everyone has access.
Yeah, and I would just piggyback on that and say Medicare does not cover obesity treatment for older adults, Medicare Part D, and it's critically important for older adults. And NCOA currently has a letter writing campaign trying to get our older adults to engage and urge Congress to pass the Treat, Reduce Obesity Act, which is urging for coverage, and not just coverage of treatment, but also of expanding Medicare Part D and to cover the intensive behavioral therapy that we know can happen in places to meet people where they are, which is not currently the case.
Susan, I think it's worth us acknowledging too. So we talked about treatment side there, and I want to say that there are other efforts undergoing that look at the prevention side of this as well. One of the things that I think area where we could invest more time and resources from a policy standpoint is actually researching the underlying causes of obesity, right? There's a lot of people who think they know the answer to that, but it's not actually, it's not as clear as people think, right? Oh, it's just we eat too much and we move too little, but what causes that? Our bodies are pretty amazing things, and they typically balance off when you eat food. So what is disrupting our endocrine systems? Is it chemicals? Is it plastics? Is it a virus? We've seen all kinds of unique things that are out there in the environment and we got to be careful in the assumptions we make. So that's another area where I think there's still some work to be done, is actually to better understand this. It's easy, and don't get me wrong, I do believe they have some culpability here, but it's easy to blame the soda industry or the food industry or modern society where we're don't have as much movement in our jobs. But I think the problem is actually more complicated than that. And I think we're sometimes, by just focusing on those narrow areas, we're doing a disservice to those of us who struggle to really not understand that. Because, when we're talking about addressing obesity, we're not talking about cures right now, right? We only have ways to manage obesity. We don't have cures. And that might be the next area that we have to work on. So.
Right. And I think that's a great point, whether, getting at those biological genetic underpinnings that can help us better understand. That's something that we pursue for every disease. But I could see how stigma would drive a lack of attention on that in this area. We're a little too comfortable with the stories we already tell ourselves about what's going on here. So I'm gonna move over to questions from the audience in just a moment. So I'm gonna maybe ask one last question of my own before I do that. So folks on the line, you should be getting ready and populating the chat box, or you're welcome to come off mute and speak directly to the presenters. If you could tell this audience and the audience of thousands that we wish we were speaking to right now, one thing that they could go out and do differently tomorrow to be sort of a better ally in this issue, what would you tell them to do? I surprised you with that one, sorry.
I think I would just say that the simple truth is that older adults face not only weight bias, but ageism when it comes to seeking care for obesity. And it's especially concerning because older adults deserve tailored plans for their care overall, right? They have unique challenges. They need to see a geriatrician or another clinician who has expertise in dealing with older adults. They also deserve and have the right to see someone who knows how to treat obesity and provide obesity care that's meaningful and give them choices, right? Many older adults, many Americans don't even know that they can get treated for obesity. And so we should be making that available. We should be helping them with that information so that they know what their options are, and they should have access to those options to have a meaningful and be treated with dignity in terms of quality of life. So that's what I would say.
Two things from me. One to everyone listening today. I would encourage you to check your bias, right? Actually see, ask yourself, am I treating people with obesity differently? And because we can't even start to address this issue unless we start with ourselves, right? And say, hey, are we doing this? So, next time you see someone who is of a larger body, ask yourself, what do I think about this person differently? Am I making assumptions about them? And if you are, then challenge yourself not to do that. I remind folks, you might see someone walk by your window right now and they may weigh 400 pounds. You know nothing about their health or their circumstances. You don't know if a year ago they weighed 500 pounds and they've done something remarkable, which is lose 100 pounds. You don't know if they're on a medicine that's causing that. You don't know if they've spent a lifetime trying to address these issues. And so it's important that we not kind of have those biases. The other thing I would just challenge anyone here, and Dorothea sort of went there with her comment. And so if you are a person with obesity, this is not about personal fault. You deserve care, you deserve treatment, and I would challenge you to find a healthcare provider that will guide you through that. It's not something you should do alone. This should all be done under the guidance of a healthcare provider. And if you can't find one, then you reach out to groups like mine or others, and we'll help you find a healthcare provider who really knows how to help people with obesity. It's okay to ask for help. There's lots of us out there trying and asking for help. You're not alone, right? We're here to help you.
Thank you. I think that was both of you had such beautiful remarks there to sort of close this formal part of the presentation. There is a comment in the chat that I'll give you a moment to read, and I'll put forward another question that came through. For women in midlife, this is a challenge, as it is for many communities of color and those with disabilities, which really connects to Michelle's comment in the chat. What language should we be using? We touched on this a little bit, with person first language that you talked about, Joe. Are there other, sort of language cues and that we should be adopting and doing a better job of to create that culture of respect and dignity?
I think this is all about non-judgment, right? And I will just be very clear. So I think as a healthcare community and as medical providers, we should use person-first language as much as possible. But it's also then important that we respect the language that individual themselves chooses to use to address themselves. Now, if in that language choice as a healthcare provider, you sometimes can pick up that they have some internalized bias as well. So if they're describing themselves with very negative terminology, it might be time to send them off to some, mental health care. We don't talk about that a lot, but there's actually, mental health support's a huge, important part of obesity care. So I would encourage people to think about that and recognize that. I also think that the populations that you highlighted, whether it's women at mid-age, if it's those that live with disabilities, if it's we have to understand that everyone's circumstances are different. That's why a one-size-fits-all approach isn't the way to go about this, right? We have to customize solutions. So, if you're a if you have a disability that limits your ability to engage in physical activity or the typical types of physical activity, you can't just be in a program that recommends the typical kinds of physical activity, right? You have to adjust. And I see a lot of the programs out there are sort of one size fits all. My other con of some of the programs that say out there like 12 weeks or 16 weeks long. No, I mean, if you have obesity, I know this is hard for some people to hear, but you're going to struggle with this for your entire life. I wish there wasn't a day I didn't struggle with my weight, but the reality is I still struggle with it every day. And so I think we have to design programs around that and really make this is personalized medicine, right? We are talking about personalized medicine moving forward, and that is the hardest part. So.
Yeah, and I would say that I get this question a lot because in community, people don't talk about obesity. And so the question is, should we be saying healthy weight or health or, weight? And all those are good. But if you don't call obesity a disease, which it is, then we will never have acceptance of it in the way that we're hoping to see, right? We want people to recognize it is a disease. It deserves to have the medical attention and society's support to deliver care. I mean, it's a moral obligation, right? We want to set the tone that it's a disease and that it's not your fault and that you deserve to work on this and have access to be able to work on it in a way that's right for you. And you can't do that unless you're empowered with the information. So I would say it's important to have supportive language. It's important to have, consider the moral tone of how you're talking about obesity. And if you avoid the word, then I think it's just feeding into the problem.
Right. It
So I
sort
will
of
say,
harkens
Dorothy,
back to the days when we used to whisper the word cancer, that somehow the
right.
word was negative. And there
Yeah.
is someone in the chat saying, is it preferable to refer to obesity as a disease or a condition?
Yeah, I'm pretty passionate, I think Dorothy is too, about us labeling these as diseases. And I want to give another reason for this too, that it's worth us talking about this way. So I am perfectly fine for a provider, again, utilizing the patient prefers, right? So I actually ask every provider, and again, people ask me, well, we don't ask permission to talk about any other condition, but why do you ask? So I tell people, ask permission to have a conversation with your patient about your weight, and then ask them what terminology they prefer when talking about their weight, right? Kind of thing. And so there are many providers who don't use the O word, right, until they have to, right, which is the obesity word, right? But I will tell you why it's important that you do have it eventually. So almost all of us now, when we go to the doctor, we have access to the notes, right? We get these after action reports from the electronic health record. And if the first time I've seen the word obesity is on that report and you've never told me what that means or what it is, and basically, let's be honest with you, most people's EHR automatically puts it on there if their BMI is above 30, and you didn't talk to me about that's a problem, right? You're actually adding to the stigma there. And then keep in mind, a lot of times those codes, and we're working, actually, there's a big advocacy effort that a number of us are participating in to change the language around those codes, but they're labeled terribly, right? So the code will say obesity due to excess calories. How do you know it's due to excess? I mean, it's just a label.
Especially when you haven't even had a conversation.
And you haven't had a right, or it may have some of the old terminology we used to use, which is a word that I think really needs to be stricken from vocabulary. But there's the term morbid obesity, which meaning you have a BMI over 40, and that morbid obesity is just terrible language. Our preferred terminology would be severe obesity or class 3 obesity. But it's important that you have that conversation about it if you know it's going to appear on your patient's electronic health record. And so again, I actually just this morning was proofing a piece and it called obesity a medical condition. It said all the right things, but my subtle suggestion was that they change that to disease and then explain what that means, right? Kind of thing. So yeah.
Right, because it places it in the appropriate context, right? A disease is something that we expect our medical system to work with us and the insurers that we pay into to have coverage to be, part of a solution to a disease. And I can see how that would be powerful in sort of making that switch.
Right. It also helps with the stigma. It helps with the stigma, right? Because it's you can say there is some stigmas around her having certain diseases, but this issue is so complex. I mean, one of the reasons our organization since 2005 has referred to obesity as a disease so well, kind of before it became popular to do so, but it's because of the complexity, right? Not, again, this is not a simple problem, right? And there's many forces at play, and so therefore, to us, that meets the disease definition.
And I want to just briefly go back to something in the comment from Michelle that we didn't really get a chance to touch on. And I wonder, Dorothea, if you might have some experience with the aging population that's relevant here. I think, Michelle, you're so on point in talking about in the population that you work with, especially children with disabilities, the role of the caregiver is such an important role. That's obviously true across the age span, but more so in certain age groups like the young and the old.
Yeah.
And so what do we know and understand about interventions being successful and well designed that are inclusive of the community and of caregivers and the people that surround the person with the disease?
That's a great question. I mean, I think, a lot of the resources could be the same, if you will, for older adults living with obesity and older adults caring for someone, a loved one living with obesity. I think the bottom line is older adults who are caregivers, anyone who's a caregiver needs to think about self-care and respite care. You need to take care of yourself. And I think that could address the question about women too. Middle-aged women are usually caregivers for their families. And so they don't put themselves and their needs first. And so then they're not as in a rested condition to take care of others. And they're constantly depleting that source of energy and life. And so I feel like one of the key elements is that people have a right to take care of themselves first so that they can be there for their loved ones. And I think that's a concept for caregivers that's especially important, but especially if you're living with obesity, because there's a lot of stress and frustration that comes along with it. So I do think it's an important question. I think caregivers and the direct care workforce is an overlooked segment of the population, and we're constantly working to provide tools and resources to help. But I think with obesity, there's similar challenges.
And Susan, I'll just add to Michelle's question. One of our challenges, we spent most of our time talking about adult obesity today, but if we think addressing adult obesity is hard, addressing child or adolescent obesity is even harder. And in fact, there might only be 50 comprehensive childhood obesity programs in the entire United States. I know we've made a big deal as a country and a nation about childhood obesity, but the reality is there aren't that many comprehensive programs to be able to address this. And so I think what Michelle's pointing out is, and when you have so few, and then when you talk about going into subpopulations there, and those needs aren't being met. But I'll be frank here. It's worth a whole nother webinar to talk about the limitations we have around addressing obesity in children, and even the idea of addressing obesity in children, which the American Academy of Pediatrics released guidelines recently that created nationwide controversy by simply suggesting that parents have a care pathway for their children. And anyway, it's that issue is specifically challenging, and people and we do need more thought, more investment, more research into children with obesity and the care that they should be receiving.
And that speaks to sort of that prevention and treatment balance. Obviously, there's gaps in terms of understanding both the biological underpinnings and the different sort of lifestyle factors that give us such higher rates of childhood obesity than many other countries. So there's a lot to learn so that we can improve for everyone. We are coming up towards the top of the hour. I feel like we could stay for another hour and talk, but I enjoy hearing from folks like you who have so much expertise. I want to turn it over to the audience. Any final questions or points that you would like to make sure get raised here in this environment? I know both Joe and Dorothea posted some resources in the chat for their organizations, different campaigns that they have going on, ways that you can sort of connect and be involved. I do think that it's, for all of our folks who are working on chronic conditions and diseases, other ones. There is so much comorbidity. There's real common cause, I think, across our community on issues related to obesity. So I think you probably have expanded your allyship a little bit here today. That's never a bad thing.
Great thing.
Susan, yeah, it's a great thing. And Susan, I would invite anyone. I mean, obviously, as we mentioned, there are 250 comorbidities or complications associated with obesity. And if your organizations are working on materials around that, don't hesitate to reach out to either Dorothy or myself. I mean, we're happy to guide just to make sure we can balance that, because sometimes we talk about your condition the wrong way, and sometimes you talk about our condition the wrong way, and trying to find the right common ground to make sure that we're working together in this. Because again, I think we don't believe people should be just treating their obesity just to look a different way, right? This is about improving their health, and we want to make sure that's reflected in the remarks that in any of the materials that we put out. So I would welcome any constructive criticism or feedback from our folks who are across different diseases to say, hey, maybe you should talk about our condition slightly differently, just like we're asking you to talk about obesity slightly differently.
Yes, we are all well served by approaching life as learners. There's always something to be gained. Any final remarks from you guys or from the audience? All right, then we will call ourselves remarkably efficient. I always like to give a gold star. Thank you both so much for being here and sharing your expertise and that of your organizations. I think there's much more to be done and to learn, certainly. And I look forward to us at the National Health Council going deeper into these issues in service of the patients that that all of our member organizations represent. So thank you very much for being so generous with your expertise today. Absolutely, my pleasure. Thank you for the invitation.
Thanks, Susan.
Thank you all, and thank you to our audience who stayed attentive and engaged.
Bye for now.
Bye, everybody.